సరే లింక్కి ఏదో పిన్ అడుగుతుంది అంటే
లేదు సార్
ఏం లేదా ఇంకా ఎవరో చూసి
నువ్వు ఆన్ చేయను ఒకసారి చూడు
మీరే ఫస్ట్ కాన్ఫరెన్స్ లైవ్
ఏం అవసరం లేదు కలుగుతుందా
మన మహీర్ నేనేమన్నా ఆన్ చేయాలి
వాట్సాప్ పెట్టినా
వాట్సాప్లో అదే
ఇదిగో మీరే దాంట్లో తీసేసి అన్న
వస్తుంది
ఇక్కడ ఆన్ చేయాలా ప్రొజెక్ట్ రెండింటికి ఒకటి అదే నాకు కూడా తెలియదు అడగట్లేదా సరే మరి క్లిక్ చేసి వీడియో అవైలబుల్ అనేది చాలా మందికి రావట్లేదేమో అదే పర్లేదు
లైవ్ వస్తుంది కదా లేదు
ఏం లేదు
చూడు ఒకసారి ఓపెన్ చేసి
సిగ్నల్ ఉందా ఈఆర్ఎస్ ఎగ్జామ్ అదే వాళ్ళు ప్రాపర్ ప్రోటోకాల్
మన కస్టడీ పిల్లలు
కిందికి విజయ్ అని వైట్ షర్ట్ వస్తానులే
ఫంక్షన్కి ఫంక్షన్కి ఇలా పర్పస్ పెట్టుకున్నాను
ఓన్ పెట్టుకోండి
వరకు కట్టడం 6 lakhs దాకా వస్తుంది. 19 ప్లస్ 19 lakhs ఏరియాస్ది 25 lakhs వస్తుంది. వచ్చినంటే నేను చెప్తాను. Welcome all of you to the CME program sponsored by KIMS Hospitals, KURNOOL. First, I would like to call upon our President, Dr. Sir, to come onto the stage. I would like to ask Vijay Bhaskar Reddy to present a medal for the President. Golden. Next, I would like to call Dr. J. Ravikrishna sir, former President IMA AP State, to come onto the stage. Next, I would like to call Dr. Masudan Rao sir, ex-President IMA Nandyal, to come onto the stage. Immediate past IMA President IMA Nandyal. Next, I would like to call Secretary IMA Nandyal, Mohammad Rufi, to come onto the stage.
మీటింగ్
Today's speakers,
మెసేజ్
Dr. Sumant Kumar, neurosurgeon. Topic on KIMS KURNOOL neurosurgery update. I would like to ask Sumant Kumar to come onto the stage. Next, I would like to call pulmonology consultants who will be presenting innovations in interventional pulmonology, defining diagnosis and therapy. They both are from KURNOOL, KIMS. Dr. Yashovardhan, pulmonologist, to come on the stage, and the other pulmonologist is Dr. M. Chiranjeevi Reddy, interventional pulmonologist, to come onto the stage. Next, I would like to ask our President to present the CME.
Good evening all. Today's CME sponsored by KIMS KURNOOL. That is, one topic is neurology update and updates in pulmonology by the interventional pulmonologist, 2 speakers. These are new trends in present scenario, so utilize the opportunity from KIMS KURNOOL to all IMA Nandyal. Next, recently రేపు March 1st Sunday ఈవినింగ్ సూరజ్ గ్రాండ్లో ఇఫ్తార్ విందు ఉంటుంది. ఎలాగైతే మనం క్రిస్టియన్స్కి చేసామో అలాగే ముస్లిమ్స్కి మెయిన్ ఫెస్టివల్ రంజాన్కి సందర్భంగా మనం ముస్లిం సోదరులందరికీ, ఐఎంఏ సోదరులందరికీ మనం ఇఫ్తార్ విందుకి ఆ రోజు ప్లాన్ చేశాము. సో అందరూ ఆ ఇఫ్తార్ విందుకి సూరజ్ గ్రాండ్ ఈవినింగ్ 6కి అయిపోతుంది. ఆ తర్వాత వాళ్ళ ప్రేయర్ అయిపోయిన తర్వాత మనకి ఒక ప్రేయర్ లాగా చేసి మిగతాది ప్రోగ్రాము ఎన్ఎండి ఫరూక్ గారు కూడా ఆ రోజు అటెండ్ అవుతారని ఆశిస్తున్నాం. సో ఈ ప్రోగ్రామ్ని యూటిలైజ్ చేసుకొని దీనికి స్పాన్సర్ చేసినందుకు కిమ్స్ కర్నూలు వారికి నా ధన్యవాదాలు తెలియజేసుకుంటూ థ్యాంక్ యూ అనండి.
Next, I would like to ask Dr. Ramakrishna sir to address the scene.
Today's CME program being organized by IMA Nanjal in association with KIMS Hospital, KURNOOL, the presiding officer, IMA Nanjal branch president, Dr. Srinivasarao Garu, and Secretary Dr. Muhammad Rafi, and Eminent Pastor IMA Nanjal branch president Dr. Masudan Rao Garu, Joint Secretary IMA State Dr. B. Panil Kumar, and today's speakers Dr. Sumant Garu, Dr. Chiranjeev Reddy Garu, Dr. Yashavardhan Garu, and my dear senior friends and colleagues. There are a few important information things to share with all of you. Last month, APMC Medical Council election has been conducted, and our AMA Nanjal branch member Dr. Bhargavardhan Reddy entered the election fray in the last moment. On 27th, he filed nomination, but we, in spite of only 1 week time, in the 1 week time we could able to procure nearly 4,664 votes in the IMA in the state, even more than 2,000 votes than important leaders in the state. So we thank all the members of IMA Nanjal for extending support and propagating and requesting all their colleagues in living in other branches to vote for Dr. Bhargavardhan Reddy. So next time we will plan much more better in advance, and I hope many more members will elect from Nanjal to every medical council. And I congratulate Dr. Bhargavardhan Reddy for coming forward to contest for the election also. And already Dr. President informed that we are going to organize a Iftar dinner party on 1st March evening at 6 p.m. in Suraj Grand 6th floor. Dr. Sri NMD Farooq Garu, Minister of Law and Minority Welfare Department, is chief guest on that occasion. He will attend the program from 6 p.m. So we request all the IMA members to attend the Iftar dinner party hosted by Muslim doctors of IMA Nanjal in association with IMA Nanjal. We are celebrating Sankranti festival, we are celebrating the Christmas, and also we are celebrating the Iftar also. And on 8th, there is International Women's Day, and Women Doctors Wing, as usual, very vibrant wing in our state. IMA Nanjal Women Doctors Wing is organizing a lot of service activities. They are presenting to sewing missions to the Navjeevan Dependam School girls for their vocational training, sponsored by Dr. Madhvi and Dr. Narmada and other members of the Women Doctors Wing. And the evening also they are organizing CME and get-together program by Women Doctors Wing and Nanjal Obstetric and Gynecological Society. So I request all those members of IMA Nanjal to make the programs on that day also successful. On March 28th, once again a CME program in association with KIMS KURNOOL Pediatric Department will be held. And from the last CME we have conducted on 25th January, a one-day CME program with 16 speakers, and all the 16 speakers from IMA Nanjal branch only. And that is the first time in the state a branch presenting 16 speakers in one day CME program with the CME credit hours. From that day, we have started our IMA Nanjal update, medical update, IMA Nanjal YouTube channel. So we will be updating all our CME programs into that YouTube channel. Today also we are recording, and this CME program is being given as a live YouTube streaming. And after that program will be completed, this will be uploaded into the medical update IMA Nanjal YouTube channel. I request all the members of IMA Nanjal to subscribe that medical update IMA Nanjal YouTube channel and promote it in your colleagues. So it will be a continuous process, and we will record and update all the medical information, discussions and panel discussions into the YouTube channel. And another YouTube channel we are planning to start on behalf of the IMA Nanjal is Public Health Education YouTube channel. In that, IMA Nanjal members can contribute to educate the public on different aspects of health issues. So it will be started in the month of March. And on March 15th, IMA Nanjal is hosting Zone 3 IMA UP State President Secretary's training program workshop in Madhubani Nursing Home Conference Hall on March 15th. So I congratulate the present team of Dr. Srinivasrao, Dr. Rafi, and Treasurer Dr. Harita and other women doctors for doing excellent activities, both academic activities and service activities. And already number already 34 programs have completed, and Dr. Masudra started the numbering the scheme programs. So it is easy for the people living in other branches to know how many activities are being organized in IMA Nanjal. So once again, I congratulate the leaders and all the members for the active participation. And one more academic event in the pipeline is the UCON. I hope after the completion of the 10th and intermediate examinations, we will plan the UCON program. That UCON program, I have conducted this when I was state IMA president. UCON, all the speakers, chairpersons, and even the APMC observer as women doctors, nearly 2,500 registrations have registered for the online program. We have conducted an online program. So this year we have invited the speakers from all over the state for that state event. IMA Nanjal will present all the women doctors speakers from the Nanjal, and it will be link will be shared throughout the country so that we can showcase the academic talent of the IMA Nanjal women doctors. So these are the programs in the pipeline, and with these things, I thank everybody for this program.
I would like to ask our Secretary Rafi to say a few words.
Good evening to respected dignitaries, seniors and my dear friends. So, on the holy month of Ramadan is going on. Actually, being secretary of IMA Nanjal, I started free OP for 1 month. So, without any OP consultation fee, I am doing services to the patients who have come to my OP from 9 to 5. And next thing is day after tomorrow, that is March 1st, we are conducting IMA Iftar get-together party at Suraj Grand, evening at 6 p.m. So I request everyone to join the occasion and grace the occasion. And next, so today's CME is sponsored by KIMS Hospital, so they are speaking, means their topics are on pulmonology. So when I was doing my PG, my boss used to say, if you are not updated, you are outdated. So being in medical profession, we should keep on updating ourselves in our own field, and at the same time we should look other fields also, what are the interventions and the inventions they are doing, and we should be updated in other departments also. Thank you for giving me the opportunity, and let us start the program.
And we would like to congratulate and thank Dr. Rafi for coming forward to conduct 1 month OPD free for the poor people. Congratulations, Rafi, and thank you on behalf of the IMA Nanjar for making such a service activity for the benefit of the poor people in the town and surrounding areas.
I would like to ask President and other dignitaries to present mementos for the speakers.
Good evening, everyone. I am Dr. Reddy, consultant intervention pulmonologist, KIMS KURNOOL hospitals.
From KIMS KURNOOL. Yeah, I think we'll like to start the session after this photo session. Thank you. I would like to ask Dr. Vijay Bhaskar Reddy. for IMA prayer.
Kindly stand and repeat along with me. May everybody be happy. May every one of us see to it that nobody suffers from any pain or sorrow. I do not ask for throne, nor I wish to be in heaven or reborn. I only want to alleviate the suffering of those people who are burning in fire of sorrow. Long live IMA, Jai Hind. Flag salutation, you don't need to repeat, just stand. We, the members of Indian Medical Association, stand here to salute our national flag. Its honor and glory shall be our light and strength, and its course shall be our course. We pledge our allegiance to it, and realizing our responsibilities as the accredited members of this national organization, we swear we will dedicate everything in our power to see it fly high in the Committee of Nations. Jai Hind, long live IMA.
Wonderful good evening to all members of IMA Nandya. So today the CME is from KIMS KURNOOL and Anantapur. So the first speaker is my roommate, my close friend, Dr. Yashovardhan Mahiseti. Actually, he was doing so much of advanced interventional pulmonology work in Anantapur. He developed the department of interventional pulmonology in KIMS Anantapur. And I thought, okay, you are doing so much and not many people know about what's the updates in interventional pulmonology. So I told him just give a CME, and then he spoke with his KIMS team, and here we are today. So this is just a brief resume. It's not brief. He did his MBBS from KMC. We both are from same batchmate, and MD and DNB pulmonology. Then he did his EDARM from Switzerland, FAIB, and also FAI from PGI Chandigarh, that is allergy and immunotherapy. I am his junior now in that course from PGI Chandigarh Institute. And also he went to Malaysia for advanced interventional pulmonology. PGI, he has done allergy and asthma, and certified sleep specialist from ISD New Delhi, and we both fight a lot in this field because I have a surgeon perspective, he has a clinical perspective in snoring. And then after finishing all of these degrees, then he was like, where should I settle? And his hometown was Anantapur, and KIMS did extend a good hand in developing the international pulmonology, first of its kind in entire Rayalaseema. And he was pioneer in developing all the department there and doing so many advanced procedures. So he's also national faculty for NAPCON, BROMCON, and he's now national faculty in the field of interventional pulmonology. And as you can see, he's a member of many societies, and he's also recently certified European Respiratory Board Pulmonology Specialization. He has passed that test, and I'm proud that he was my roommate in UG, and we both were so close. We did so many things, naughty, nasty things. We both were in disciplinary committee meetings in KFC, I think, but after finishing our AGs, we chose our careers in a nice way. And speaking of when he was trying to take pulmonology, I was like, why are you taking that branch? All due respect to pulmo. But he was, no, not many people know about that. Now international pulmonology is being picked up. And post-COVID, now this department has blown out in a big way. Of course, it's a costly department, but still I think Yasho is, I've sent few cases to him to Anantapur. He's also very patient-friendly in financial aspects. And also he is now co-fellow, his fellow from Dr. Chiranjeevi Reddy. He has now started interventional pulmonology in KIMS Kurnool. So he is the second speaker of today. He is also trained in advanced interventional pulmonology with linear nebus, radial nebus, cryo, rigid bronch, APC, and rigid thoracoscope. So both of them, I think, done their fellowship from Yashoda. So it's one of a kind fellowship, and you'll see why the Pulmo department has taken a huge step from his lectures. The kind of cases that scenarios that he presents are very unique. I know all of them because we discuss a lot. So I welcome Dr. Yasho to give this talk on advanced interventional pulmonology. Thank you.
That was heavy.
Zoom just.
I'd like to introduce Dr. Sumant Kumar N. Also, he's a consultant neurosurgeon at KIMS Kurnool. He had his graduation from Siddhartha Medical College from 2001 to 7 and DNB neurosurgery from Apollo Hospitals Chennai 2010 to 16. He had postdoctoral doctorate fellowship training in the neurovascular skull base from SRM Institute, and then WFNS adult microneurosurgery in University Hospital Germany, and his expertise is in brain and spinal cord tumors, neurovascular aneurysms and carotid artery disease and bypass surgeries, endoscopic brain surgeries. He is especially very much interested in pediatric neurosurgeries, and he is having special interest in neurotrauma, head and spine injuries, CSF diversion procedures and microscopic spinal surgeries. Specific focus is in microscopic endoscopic neurosurgeries. Thank you for giving me these opportunities.
So it's already late, it will start. So very good evening everyone. Respected seniors and colleagues, this place has always been special to me. I used to come here for vacations, for good food and fun, but coming here for academic is always special to me. With more, it means so special to me now. Deep has always been like a brother to me, and Madhusudhan uncle, he have been godfather for us, for any like one-stop solution for career guidance and life advices. So I carry immense respect for you, sir, and thank you so much for having us here. And thank you, IMA, on behalf of this opportunity. And on behalf of KIMS Kurnool, me, Dr. Yashovardhan Mangishetty, I'm an advanced international pulmonologist working for KIMS Anantapur and KIMS Kurnool. And my colleague, Dr. Chiranjeevi Reddy, consultant international pulmonologist working for KIMS Kurnool. So we all treat the same patients, the one who comes breathless at 2 a.m. The one comes with the complex lung shadows. And whatever we give, some cases you don't see any improvement. And today I want to show how advanced procedures can change those outcomes. And so I promise you one thing today. After this session, you will never look at a lung lesion, a pleural effusion or a collapsed lung the same way. So because today's pulmonology is not just about diagnosis, it is about precision, impact and intervention. I am here not just to share the procedures, but to share the possibilities, because interventional pulmonology is no longer something that is happening very far away. It is something that is made accessible right here for our patients, our hospitals and our community. To start with, I will be taking you through the real cases from our center. Some are challenging and some are humbling. Coming to the indications of bronchoscopy, to evaluate the symptoms could be persistent cough, chronic dyspnea, hemoptysis, coarseness, stridor. To evaluate clinical findings could be suspected aspiration, we do bronchoscopy, suspected malignancy, we do bronchoscopy. Recurrent pneumonia, we do bronchoscopy. Pneumonia pulmonary etiology, we do bronchoscopy. Suspected PPF, we do bronchoscopy. And according to American Chest And according to American chest physicians, to perform interventions require additional training and expertise beyond standard training program. The role of fiber optic bronchoscopy could be diagnostic. This is what we do: bronchial lavage, endobronchial biopsies, transbronchial lung biopsies, leaded endobronchial ultrasound, radial endobronchial ultrasound, thoracoscopy. To say therapeutic, we do receive bronchoscopy, airway deobstructions, and dilation, foreign body extractions, and the list go on. Coming to the diagnostic interventions, let me ask you a simple question. How many of you all have seen a patient completely cured from lung cancer, living a normal and long life? How many of you all have seen a patient completely cured from lung cancer, living a normal and long life? Like what we routinely see with breast cancers or prostate cancers. The very uncomfortable truth is very few. Can you accept with me? It's very few. Not because lung cancer is untreatable, but because it is diagnosed late. You know why? Because we are living in a country like India, where there is enormous burden of TB, has shaped how we think. See, if you see mediastinal lymph nodes, probably TB, lung nodules, probably TB, pleural effusion, start ATT. And in this process, lung cancer slightly advances, and this is where exactly interventional pulmonology has a role. And we change the story. Instead of assuming we sample, instead of waiting, we diagnose early. And to sample around the central airways, we have linear endobronchial ultrasound. That is how it works. We stay in the central airway. We just perform a scan staying in the endobronchial area. We see what is next to the wall. Say the lymph nodes that are around the central airways could be station 2R, 2L, 4R, 4L, 10R, 10L, 11R, 11 and 7. All these lymph nodes can be assessed by performing a endobronchial ultrasound, and real time we go and sample it. If the lesion is more peripheral, then what? If the lesion is more peripheral, we do radial endobronchial ultrasound. We put a probe, search east and the other segment, we perform a scan endobronchially on the 360 degree, we see where the lesion, go and sample it. And if the lesion is more around the pleura, then what? We do have thoracoscopy, we just give a cut, approach from through the chest wall, go into the pleural space, see the pleura and sample it. So more about EVAS. Traditional technique of sampling mediastinal lymph node used to be mediastinoscopy, where surgeon used to cut open, search for lymph nodes, and that has been replaced by a daycare procedure now. It is an endobronchial ultrasound, where I told you we stay inside the airway. It is a daycare procedure. We stay inside the airway, just we perform a scan staying inside the airway, we see what is next to the wall. So all the lymph nodes that are around the airways can be easily sampled. These are the stations what I was talking about, who are around the central airways. That is how we pass a needle in on real time. Even we perform spacing endobronchial ultrasound. The tumor is more on the right. Say this tumor is on the right, then we perform scanning from the contralateral lung. We consider this as N3. We perform scan over here. We sample it. Then we come to N2. We usually perform keeping a pathologist inside the OT. Soon we sample from the particular area. We give the sample to our pathologist to see and comment on it. If my pathologist comments it is a ATPR, we'll stop the procedure. It's already N3. If N3 is negative, then we'll switch to N2. N2 we perform the scan, we sample it. In N2 is again negative, we switch to N1. In N1 we see ATPR. That is a case fit for the surgery. The next day we post for the surgery and the patient is completely out of lung cancer. This is how it looks in a real patient. This our patient in KIMS, this is how it looks. This is the lymph node station 7. This is how the needle is passed. This is like FNAC. It is like taking FNAC. So the innovation has grew, not just FNAC. We are making a track. Through the same track, we have a probe called cryo probe that can freeze the tissue and pluck it. The biggest one will come out. So through the same track, we can pass the cryo probe in. We can freeze it and pluck it. You can see the size of the sample. That can make any pathologist happy to comment on it. That's all about mediastinal lymph nodes, and the lesion is more peripheral. Then what? Again, traditionally, sampling peripheral lung nodules, traditionally based on size of the nodule, we used to ask the patient, you come after 6 months, we'll see the size is going big, then we'll sample it. If the risk is less, we used to ask the patient to come after 12 months, we'll see the progression will comment on it. Now it is not there. We have the gadgets that can sample the nodule irrespective of the size and the location. So what we have is something called navigational bronchoscopy. What we do in this? What we do in this, we perform a 550 cut proper HRCT, we upload that particular CT into a software called a lung point. The lung point will convert this CT into a virtual animated picture. This is how it shows the video. It is like a GPS track. Where you want to go. If you want to go home, you have a GPS track, go right, take left, go up, go down, go left. That is your home. That is how it shows the location of the nodule. Using this navigational bronchoscopy, we go into the patient with the same track and get the nodule out. And now innovation has proved if a nodule has no road, it is like you don't have a particular road, you have a road by your home, so it is not showing in your GPS. Then what? Then it is advanced, we have something called Archimedes. Archimedes will dug a tunnel. Once the road is not there to go to this particular segment is not showing airway to reach your nodule, then that particular area where you can reach the nodule, from that area in the airway you can form a tunnel and reach the nodule. That is Archimedes, so that we can go and sample from any area of the lung that is possible. Whatever gadget you use, it could be navigational bronchoscopy or else a manual mapping, or very good at CT, you know where it is, go subsegmental, you got it. Whatever gadget you use, however you go, finally we make sure we are at the right location by doing radial endobronchial ultrasound. This is how it is. We perform a scan, 360 degree around the airway, we see whether we are at the right area or not before sampling it. However, we have our pathologist helping us whether we want to change the area of sample or change the pathologist. This is how it looks in real time. The 360 degree endobronchial ultrasound probe that can perform a scan, staying inside the airway, segment, subsegmental level, scanning 360 degree around the airways to reach your peripheral lung nodule and sample it. That is how we search one of the other segment. That segment we didn't find any lesion. Then what? We are searching for the other segment. Usually what I perform, I go in a clockwise not to miss any segments. If I go here, then I will go 3 o'clock, then 6 o'clock, then 9 o'clock, not to miss any segment. So this segment I have performed as per the clockwise what I am talking about. There we found a lesion, yes. This is how it looks, the nodule, the right location. We use the help of the fluoroscopy, we know where we are, we go there, we use the axillary, the brush, forceps, toyo, whatever, chunk of tissue, whatever we need. Based on the axillary, we go and sample it out. This is our article published on it. I have spoken enough about cryo. This is how it looks, the animated picture of cryo. It is a cryo, it is an advancement where we can freeze the tissue and plug it to get a bigger chunk. Okay, this is in a tricky location. This case in a tricky location somewhere in the left upper lobe, apico-posterior, somewhere very deep in the chest wall. So we cannot assess with the radial levers what it was planning up to. Then we have done something called cone beam computed tomography. We have a 3D imaging, 3D CT. So what we have done, we have performed a 3D CT. Then we have cross-checked with the radial endobronchial ultrasound where we are. It is how it is. The CT is rotating and we are getting a 3D picture, not just 2D. Anterior, posterior, would not be confused. And so we know where we are and we are using radial endobronchial ultrasound, trying to locate the lesion. That is how. We have located the lesion now, and under fluoro also we know where we are. Then what we have performed? We have performed. Usually I prefer performing cryo only because of I'm more concerned about getting a bigger chunk of the tissue. I'm much scared about that landing in a dead end, not getting the diagnosis. This is the cryo probe what I was talking about. This is how we go in. Once we know the lesion based on the fluoro, 3D fluoro, we go in with the cryo probe. Then we are freezing it. We are plugging it on. Just imagine we are just getting a bigger piece from the lung staying in the bronchial. Does it bleed or it will bleed? It will definitely bleed. Then what? Nobody dies of hypotension by bleeding inside the lung. People die of ventilation failure, correct? Blood pools into the lung, ventilation gets failure. Then what we do? We use a Fogarty balloon. We place a balloon just behind the operating side That is how we place. We place a balloon just behind the operating side. Once I perform a biopsy, my balloon will pop up. My balloon will pop up and conceal the bleed to that particular segment, allowing not to spill to the other segments and compromising with the ventilation. So that particular segment is already blocked. So we are very much rushed in going back again to see whether balloon is in the right area or not. If balloon is dislodged, we are in big trouble. The same sample, then we have a pathologist, as I told you, we are given to a pathologist coming to be atypical cells. You can see the size of the sample, what we have got here. Size of the sample, this is the atypia, what we can see. This is the radial, I'm just showing the OT thing, how we do it. And this is the 3D picture, where we know we're exactly in the center of the lesion, what the sample got. That is how the scenario in the book. So this is the row list of atypical cells. Usually we perform staging endobronchial ultrasound once we know the peripheral lung lesion is showing atypia. In this particular case, we didn't proceed for staging EBUS just because PET has already shown mets in the some other area. But in this patient, PET has shown nothing other than the lesion in the lung. So this patient, again, we have performed endobronchial ultrasound. They isolated the lesion. Then we parked our balloon just behind the operating site, not allowing bed to spill to the other segments. Then we have used cryo, we have freeze it and plugged it, we have got a bigger chunk. Then the row size of ATPR. Then we didn't stop the procedure there, we want to continue with staging endobronchial ultrasound. The same sitting we converted into be linear EBUS. So linear EBUS, we started performing scan, looking for the bilateral lymph nodes from the contralateral lung, as I told you, N3 is negative. In this particular patient, N2, the subkernel and the 4R was positive. So this is not a case fit for the surgery, but still we have staged it to N2 cancer. That is how the balloon looks like. So coming to pleural interventions, we do thoracoscopy pleural biopsy. The area is difficult to assess. We have flexible thoracoscopy where we go, we use cryo and freeze and click a bigger channel. It's all about diagnostics. Coming to therapeutic intervention, whatever therapeutic we do under rigid bronchoscopy, this is how the barrel looks. It is like just putting a metal barrel into the airway, in central airway. And again, to deal with central airways, it used to be a major catastrophic surgery which has very high mortality. Where surgeon used to have to cut and stomach the central airways. Now we just stay within the airways. That could be stenosis, we dilate and stunt it. That could be tumor, we cautery and ablate it. Could be foreign body or clots, plugs, we extract it. Could be tracheoesophageal fistula, again we put a stunt. We deal with all the intrinsic, extrinsic and mixed obstructions. We got accessories, could be hot and cold therapies. We got organoplasma coagulation, lasers, cryo, electrocautery. These are the stents what we have, could be metallic, silicone. This is how stenting looks like. First we perform a rigid bronchoscopy intubation. That is how we perform intubation. We just go into the central airway and you can see the narrowest lumen, hardly 2 mm lumen was there for ventilation. Then what we have done, we have put balloons called CRA balloons to dilate it, to go in and dilate it. So once we have enough space, we do mechanical dilation by negotiating our rigid barrel next to the stenotic segment. We just do mechanical dilation, we just negotiate our rigid barrel next to stenotic segment. So my barrel is around 13 mm, so we can dilate to 13 mm by the barrel itself. That is how we negotiate. We are just cutting down the tags. So once it is dilated, then what? It can again reach stenos, correct? That is the reason we thought of putting a stent over there, not allowing it to get raised stenos. This is the silicone stent what we have placed to this particular patient. We are just mobilizing the stent at the right area to cover up the stenotic segment. That is how we drop and mobilize and this is how it looks post the completely recanalized lumen. This is the pre and post. This is the pre, the post lumen. And he has come for a recent check bronchoscopy with us. He has maintained a stent like next level, and we are very happy that we are about to remove the stent now. Similar case, This is again a 42-year-old male with a distal tracheal tumor. You can see the tumor is completely upsetting the trachea, hardly air is leaking around the tumor. This particular patient we have taken under emergency, we have done a rigid bronchoscopy intubation, we have used electrocorticoid snare to cut it, and we have cryo, a pivot probe to freeze it, and so we have frozen it and we extracted it. That is how it looks post procedure. The next day discharge stable. A similar case, 62-year-old male smoker came to us with severe respiratory distress taken for state bronchoscopy. What we have seen is completely infiltrated tumor into the left main bronchus. We are trying to sneak what is next to the tumor from the airway. Complete left lung is infiltrated and sealed inside. So what we have taken for rigid bronchoscopy again. We started removing chunk one after the other. It almost 1.5 hours for us to remove it. This is how it looks pre-procedure, completely infiltrated and sealed airway, nothing left for the air to go in. And you can see the post-extraction, completely extracted lumen, completely recanalized. You can hardly see the stump over there. The left lower lobe is opened up, apical segment opened up, then the upper lobe lingual is opened up, upper division upper lobe. Here you can see the posterior segment. That's it. This is the extracted chunk. It may look small but very big inside the airway. And a 72-year-old female who is a known case of esophageal cancer being to us with severe stridor, asking for to improve the quality of their life. And what we have thought, sir, because of this extensive compression of our airway, upsetting the lumen more than almost 90%. Then what we have thought of placing a metallic stent this time, not the silicone, because we want enough pressure from the stent not to get it upward posteriorly. So what we have done, because it is metallic, we can place under a fluoro. So before taking, we can just mark our distal and proximal ends where to deploy the stent. We do a bronchoscopy, we see the distal end of the stenotic segment, then we put a mark. Then proximal end, we put a mark. Based on the length and size, we decide what stent to be placed. Under fluoro, this is how we drop a stent. This is how it goes. Stent placement. This is the bronchoscopic picture after the stent placement, completely recanalized lumen. The patient was discharged stable the next day. That is how it was, a flower with stent. This is a patient. A similar case, almost similar age also, non-CA cancers. But this particular patient not just has extensive compression, but this particular patient has necrosis also. It was already all the posterior wall was necrosed, formed a big fistula. So you can see this, all the necrotic chunk with a big fistula. So this patient not just preventing esophagus to push the airway causing stridor, also to manage the fistula to prevent aspiration. So this particular patient we have taken for a stent placement, it will be little bigger size for this patient just to seal make sure to seal the fistula. So we are just trying to remove the extra chunks just to beautify this, just to oppose our stent properly to the walls. We are just trying to remove the chunks. Once the chunks are removed, the ground is clean. This particular patient, a new stent is into the market called a through the scope stenting. Without using fluoro, we can just place the stent under bronchoscopy itself. Maybe we are the first team to use this particular stent in Andhra Pradesh. Maybe we are lucky to get it first, maybe. That is how we place, through the scope stenting. This has little different in shape and quality. The completely sealed fistula, recanalized lumen. That is how it looks. All the necrotic part is sealed up. Looking like a flower. Done. So not just about the central airway, this particular patient has tumor infiltrated into the right main bronchus, completely obstructing the right main bronchus. Because he has an underlying little sensitive airway because of smoking, he was recurrently getting admitted with recurrent bronchospasms and complete absent right side breath sounds, respiratory distress. And so this particular patient, we thought of placing a stent to open up the extensive compression, putting a bronchial stent in the right main bronchus. That is how we put a balloon again. We want to dilate mechanically to make a room. Then once we make a room, then we want to put a stent just to cover all the compression area to recanalize the room and allow the ventilation. That is how we have dilated it. Yes. that is through the scope setting. We are just going in. Just want to show the post processing. That is how we deployed it. This particular patient, because we are not using floral, more it is a bronchial stent that we are not very much used to. And so this stent was deployed more distal. So what we thought, we want to reposition, not to miss any stenotic area. And so what we have done repositioning. So once we are out of it, it is deployed more distal, not covering all the stenotic area. So we thought of repositioning it to the right area. That is what we are doing now. We are going in, we have tags over there on the stent that can just link it and pull it. So we went in again, we have pulled this one tag, we want to reposition, pull it to the right area. So we almost did it. Cut. Now it is almost the right area, completely recanalize the stenotic segment. That is how it looks post procedure. That is how it looks. More about stents. Then we'll talk about bronchopleural fistulas. Again, avoiding major surgery is what we have. We localize the fistula, putting a methylene blue. On some of the techniques we have with the balloons and all. This is how we put a dye and see where is the fistula. Then once we localize the fistula, we got accessories called glues. We got something that can just go in and seal it. It is like putting on a puncture. That is how we just, once we localize, we put a glue over here. We seal a particular subsegment, not allowing air to leak, allowing the expansion. This is a post, and pre and post, no air leak. In this particular patient, I want to show because it is always not easy to localize the fistula because after putting into invasive mechanical ventilation, some part of the lung get atelectasis and air won't go into that particular segment, and so we don't see any leak over there. So we use other technique called Fagati balloon, putting a Fagati balloon each and other segment. This segment, like we put a balloon, upload that segment, it is like uploading the leak, correct? Then though the air is going on, because balloon is over there, leak is concealed. So where leak is not there, we consider that particular segment is the culprit. We have tried every way, putting dye, putting balloons, every way we have tried, but we have failed in localizing the fistula. Then the innovation has come. What we have done, we have put it under fluoro. Then we have used the contrast what cardiologists use. We just drop out the contrast, staying endobronchial. Based on the suspected segments. If this segment I have a suspect, I just drop out the contrast in that particular subsegment. And we are looking for the leak of contrast under fluoro into the pleura. So once we know the contrast is leaking into the pleura from that particular segment, okay, now we know the culprit. Then, because it is a bigger fistula, we want to close the bigger segment. That is a spigot what we are using. It's like inert material. We can just go, set it over that particular segment, and we will take glue. We spray a glue just to seal that segment, to seal the fistula. That is how we go. Put. Lack of time, I'm rushing. Anything find interesting, please ask me as well. It's all about airways. Now, what happens with the pleura? In an expanded lung with the thick adhesions. Then what? What we do is adhesiolysis. Not aggressive adhesiolysis. We go in. My motto is to just communicate locule to locule. I'll just communicate one locule to the other locule. I'll allow the toileting of the pleural fluid. I'll allow the expansion. Not like beautifying things. I just communicate it. Once you try to beautify, it can tear the pleura, will end up in many more complications. So we just try to communicate the locules, empty the pleural cavity, allowing the lung to expand. In this particular patient to put up, usually we perform thoracoscopy or ICD placement in the infraaxillary area. This is one particular patient we cannot perform infraaxillary because of the lung get adherent to the chest wall. So we have converted on table to posterior approach. You can see over there where the ICD is. Posterior approach. We converted to posterior approach. This is the thickness of adhesions what we have come across. So we started removing one of the other segments, communicating the locules. Interestingly, once we got deep into this pleural cavity, we saw a concealed bleed inside. We saw a concealed bleed of 200 cc of blood inside. That is the source of infection for him. And so we extracted all the concealed bleed, and the adhesions were communicated, and we achieved the lung expansion. You can see the bleed again. We are almost there. The one more layer and more you can appreciate the bleed. Yes. Next to that, that's right. This is the pre and post. So little interesting thing now, a foreign body, 7-year-old male has been to us with a X-ray showing this. You can see over there, this is a metal ball. We hardly took 5 minutes for this extraction because we do have magnetic force. It is a metal ball. Once we go in, put it back, it will come and attach to it. So again, it is a 2-year-old baby, been to us with history of choking and everything, what the regular history of aspiration and all. This is what we saw inside the right main bronchus, as we said, in a peanut. I'll just show the techniques how we remove it. This is a cryo, my favorite element. We freeze it because it is organic foreign body. We can attach it. Once it is there, we can. Because subclotting areas little arrowed, we dropped it over there. Again, we went in, we got it out. That is the reason it is 2 pieces over here. We went in again, cryo is in action, we got it out. Yes. So this particular patient is almost like 60-year-old female, been to multiple hospitals last 1 year because of recurrent pneumonia. Here with some random antibiotics, you will be fine for a week. Then again complaint of fever, cough, dyspnea, again new antibiotic, again new antibiotic. To take up a check bronchoscopy, that is what we have seen. It is an organized foreign body last 1 year. You can see this. This time we have placed not a bronchoscope, it is tracheobronchoscope. So this barrel is just above the right lower lobe. Why? Because we may spill this pus over the other segments. So we make sure we are not spilling the pus. So we have taken our tracheobronchoscope rigid barrel directly on above the right lower lobe bronchus. It is just right lower lobe. So you can see this. Once you go and touch it, the pus will ooze from inside. I'll just show the oozing thing. That is a rigid forceps. So once we go in, once I touch it, it's oozing. That is how it is. It's very much organized, very much infective. So we don't want that to be spilling to some other segment. That is the reason we have used tracheobronchoscope for this particular patient, staying just above the foreign body, not allowing the spillage. That is how we got it out. This again one patient that was initially attempted somewhere else. With the castor seed in the central airway, doctors attempted, he got the seed out, saved the patient, but castor seed has shells on it. Once he got the seed out, the shells were completely dislodged deep into the lung, the right lung, left lung, everywhere. These are the chunks what we have taken them one after the other. So again, the 2-year-old male, this is not a fresh foreign body. They were being misdiagnosed for 10 days or 1-2 weeks. You can see over the granulation over there. I cannot use cryo for this because once I stick the granulation with the cryo, it will bleed like hell. Very small lung. Once you start bleeding, you may go into ventilation failure. Then what we have done, we just passed our balloon next to the foreign body. We just negotiate our balloon next to the foreign body. We inflated the balloon. We are dragging it out. That is how we are dragging it out. Once it is in the vocal cords, we have all the accessories, forceps or cryo, we can stick it and pack it out. That is how we got it. This particular foreign body to share, because as I told you, the cryo and Fogarty techniques I have showed you, this particular patient failed in both the techniques. Fogarty we have failed, cryo we have failed. Why? Because it is a seed that got into the airway that got swollen up. The seed got swollen up, completely packed the airway. It is a very huge foreign body for his lungs. It was very hard for us to get him out of the vocal cord, it's not coming out. Then what we have used, we have passed a balloon next to the foreign body, inflated the balloon, dragged the foreign body up. Once we are at the vocal cords, not to get dislodged deep, we inflated the balloon to give us a support. Then what we have done, below the balloon is there, above we went with the cryo. We went with the cryo, we stuck it, below balloon is there, with both the support, we got it out. That is at the subglottic area. The challenging part of extracting foreign bodies, basically this kind of foreign bodies is the ventilation. Anesthetist has a very big role in maintaining the ventilation of this particular patient. Usually what happens, we have enough window to get the foreign body out. So once your patient is going hypoxic or bloody or whatever, once we hear bloody, that is a sign word for us. Once we hear bloody, we do two things. While we are confident, we get it out after the vocal cord, for the central airway. If we are not sure, at least we go in and drop the foreign body in some other lung, right lung or left lung. so that we ventilate one lung is blocked. That is what we do. When we are at the central airway, we doesn't have any much window to operate. So once we are at the central airway, if we are sure, we get it out. If we are not sure, we go in, drop one of the other lung, we ventilate with one lung, we wait for some time to recover, then we will go again. That is how it is. Lack of time, just rushing, and just want to show this. Because cases of COPD, basically, there will be one coronary surgeries or more specialty surgeries. Some particular patients which are not pan-emphysema, this emphysema and the unilateral predominantly and the upper lobe predominant emphysematous lungs, we do have advancement called bronchial thermal vapor ablation. We just go into the airway, we select the segment that has to be string, reduced in volume, allowing the complex rest of the lung. We go in, we pass the thermal fumes, what I was showing here, we pass thermal fumes into the airway, we blanch the particular mucosa. So we allow that particular segments to shrink, reducing the volume, allowing the other lung to improve in the compliance. I am proud to say, maybe we are the first, I am part of the team, we are first to do in India. We have almost done almost 7 cases of this bronchial thermal vapor ablation. When I was in Malaysia, people were doing this endobronchial valve placement. It's not, they can even use for pan-emphysema also. Whatever lung wall you want to reduce right low and low apical segment. Go right low and apical segment, put your umbrella and come out. That is all. But because they practice something called Chartis system to see the collaterals and drop it. So thank you so much, and we are proud to say that our advanced interventional pulmonology suit is the first one in the Rayalaseema. Maybe among 5 suits in Andhra Pradesh, less than 100 suits in India, I guess, equipped with linear levers, radial levers, cryo 1.1, 1.7, organ plasma coagulation, all the size of rigid bronchoscopy barrels, stunt loaders, radial bronchoscopies, thoracoscopy, rigid and flexible, almost everything to run an advanced interventional pulmonology suit. And thank you so much for all the support and the attendance. Thank you so much. Anything is there, I'm pleasure to. Yes.
Thank you, Yashwardhan, for demonstrating the wonderful cases and most advanced procedures in the pulmonology. Next, I would like to call Dr. G.V. Reddy, pulmonologist, interventional pulmonologist, to present his case. Next, I would like to call Dr. Sumant Kumar for neurosurgery update.
Very good evening. First of all, I thank Nandyala IMA division for giving this opportunity. I think it's already late. I'm not going to bore much. In this crowd, I guess we have obstetrician gynecologists, general physicians, ophthalmologists, pediatricians, orthopedics, neurologists, intensivists. Why I'm saying all this is because neurosurgery is linked to all this. Just it is not about road traffic accidents or just a stroke. So because a patient might have a menstrual irregularities, but a patient might have some pituitary tumor, or patient might be having a vision ophthalmologist like visual decline, but the problem would be in the brain. So that's how the neurosurgery is linked to all our medical fraternity. So like neurosurgery, as I said, it is just not like a road traffic accidents or just a spine. So there is a lot in the neurosurgery. So here I am in front of you, like I'm a 10 years old neurosurgeon, post my residency, and I always bow my head to my professor, who is K.R. Suresh Babu sir, my mentor. from Chennai, Apollo Hospitals, who was HOD, and later he was like SRM, Institute of Medical Sciences. And my other teacher, Dr. Shankar Ganeshan. And my Germany days, I was like a World Federation of Neurosurgeon Society fellow. I was selected from India. I represented India in I was selected in 2020, but I couldn't go because of COVID. I did my further microneurosurgical oncological fellowship in Germany. This is my Professor Schumann, who is the pediatric HOD, and Professor Tata Shiva was a adult HOD, because there are two separate wings like adult and pediatric neurosurgery. As I said, neurosurgery, just not only the trauma, there is a lot like neuro-oncology, neurovascular, functional neurosurgery, infections, and of course the routine degenerative spine, that is like commonest back pain. So, and the stroke. So with all this, there is a lot that microscope and endoscopic neurosurgeries. Here, like we usually, all these neuro-oncology we need is the machines, like microscope or endoscope. So here I would like to show a few cases which are, I could say, routinely being done in metro cities. But since last 6 years, as I said, I am 10 years old, but in last 6 years I am working with KURNOOL KIMS. So here we go. This is a case one. He's a 55-year-old man. He's a mechanic by profession who presented with headache, intermittent headaches and seizures with a weakness. We could see there is a large cystic lesion in left frontal, and it is coming to the parietal also. So the probable working diagnosis, some cyst, and it's a rare, probably a hydatid cyst, maybe. So, like, if it is a hydatid cyst, it is like hydatid cyst has to be removed entirely. It is not that. So, it's a large cyst. Initially, I planned a large craniotomy to remove in total, but I just tried only the small opening. Let's see what is. It is only the small arachnoidal layer. As soon as I opened the arachnoid, it was like completely the brain is sunken. The pathology came as a neuroglial cyst. So here, why I am showing this case is here I didn't do anything like either endoscopy or microscopy. It's just a routine conventional way. But later on, it got collected again. The same, it got collected again, and the patient present on repeated MRI the same thing. So here we can see the cyst, the wall in the medially. It is with the ventricle of the. So initially I got a neuroglial cyst. This is a CSF secreting cyst. So here I can convert this into this pathology. If I open here, this CSF will enter into the normal ventricles. So here I did a endoscopic. This is a plan. This is the entry point, and this is the wall where this is between the cyst and the ventricle. So did a endoscopic fenestration of the wall, and this is pre-op. You can see the post-op. The problem is solved. So the pathology has been converted into the physiology by the simple endoscopic procedure. Next case, say young man with progressive headache, vomiting. He became drowsy, sleepy, and papillary edema, visual disturbances. It's a classical textbook PG question. On CT, what you see the calcifications with the cysts, that is the craniopharyngioma. As for a neurosurgeon, craniopharyngiomas are like, they get attached to the hypothalamic and posterior pituitary regions, and it is solid cystic. Complete removal, we cannot remove it en masse, because hypothalamic dysfunction is a dreaded complication postoperatively. So the easiest way here, what we need to deal is the hydrocephalus and also the tissue diagnosis, and for the future how to deal the same if the cyst is going to recollect. So I had to address the both hydrocephalus and the tumor. So this is what I did. This is a foramen of Monroe, like foramen that connects the lateral ventricle to the third ventricle. This is a choroid plexus we can see. So the foramen of Monroe endoscopy passed, and this tumor is at the foramen of Monroe. This is a cyst with the cholesterol crystals. We can see the cyst wall is opened, and the tube, the shunt tube, has been placed in, and this is connected to a reservoir. Like in future, for example, if the cyst get collected, we can even aspirate simply at the bedside. And craniopharyngiomas, we take a tissue biopsies, and craniopharyngiomas are well respond to the radiotherapy. So this is the simple way of dealing it. It's a pre-op, it's a post-op CT scan. The Omai reservoir was kept there, but actually this patient didn't get collected. This is nearly the 3 years follow-up after the surgery. So another case, this is also same progressive lesion. Here also we can see the supracellular area. There is a solid cystic area. Here actually we can see the fluid level also. He presented with complete visual decline. On left eye there is no perception of light. Right eye there is a field defect significantly. Here actually the tumor. Here also we can see the cyst wall is anterior to the foramen of Monroe, especially on the left side. So the same endoscopic approach. You go anterior to the foramen of Monroe. This is the foramen of Monroe because the tumor is here is a little anterior to the foramen of Monroe. Cyst is opened. All the cyst contents are aspirated. Cyst wall, whatever the inside the cyst wall was taken for the biopsy and the debulking. Later on, same, keeping the Omai reservoir placement. If that is for the future, if it is going to recollect, we can aspirate simply from the bedside. This is another case of same endoscopy. This is a posterior third ventricular region. Posterior third ventricular region, solid lesion, which led to hydrocephalus in an adult. This is like he presented with a normal pressure hydrocephalus. That is like you walking difficulty and memory disturbances. The mini-mental score examination, he was like 18 only out of 30. So here also same endoscopy. Here actually I need to deal the both. Like one is the hydrocephalus, another is the tumor. This is the tumor in the posterior third ventricular region. So for the hydrocephalus, the routine, instead of routine conventional B patient, I chose a endoscopic third ventriculostomy. That is like this track, go through the foramen of Monroe, open the floor of the third ventricle. And for the tumor, this is the trajectory. So I used it to Virgo's. And this is how the surgery. Endoscopic third ventriculostomy usually like in a pediatric patients it is like very useful pediatric patients who this is through foramen of Monroe. This is a choroid plexus, the foramen of Monroe. Scope enters through it. In pediatric patients, routinely conventionally we do ventriculoperitoneal shunt, but endoscopic third ventriculostomy is like because in a child, if we do the ventriculoperitoneal shunt, child has to live with the shunt till age. But endoscopic third ventriculostomy is creating a new channel. Child will not be a shunt dependent at all. It's the same like endoscopic third ventriculostomy video. It's a mammillary bodies. It's the floor of the third ventricle where we can open the floor of the third ventricle and inflate, open the wall and pass a Fagati there and open the cyst, open the floor further. I'm just rushing the videos because we are already late. So this before case was a posterior third ventricular region. Now this is the previous case, the lesion was here, and this is here, anterior third ventricle. This is a colloid cyst. Colloid cyst is a dangerous thing, like it hangs, it suddenly causes acute hydrocephalus. Even patient will die suddenly. So the same thing here also we have to deal with the both, like the tumor and the hydrocephalus. Yeah. So the endoscopically, the cyst is opened, the cyst contents aspirated. Septostomy, I did a septostomy, that is like attach the both right and left ventricles. Another routine is the skull base pituitary lesions who presents with hormonal disturbances and visual decline. skull base through the anterior skull base enter the sphenoid, open the sphenoid, go to the cellular floor. And most of the pituitary tumors are like soft and suckable. Usually they will have a fluid levels. Once we open the cellular floor at the durotomy, the tumor will come out. And I'll move on to the further routine microscopic surgeries. Spine, of course, we know it's a commonest, cervical myelopathy. We all routinely see. In this patient, there is a 3-level cord compression. So microscopic anterior cervical discectomy and cage placement. So another one young lady with a large carda equina level large neurofibroma. Actually, tumor is coming out through the foramen. There is an intradural and extradural also. Here we can see large extradural component of the tumor. So here is a dura, midline thecal sac, followed by this extradural component of the foramen. So both intradural component and extradural component is removed. As it is young lady and involving the lumbar and sacral, so I did even a fixation also. This is the post-op. This is a intra video how I may open the spinal cord and remove the contents. Dural repair, post-operative dural repair is very, very important because unless it's a watertight dural repair, CSF leak is a dead-end complication. Yeah, dural closure is a very important, and this is how she was post-operatively. So another case at C1 C2 junction. It's a large intradural and extramedullary tumor. This was pre-op. He was with a quadriparesis, having weakness in hand and not able to walk properly. The tumor was completely removed. All this we can do only with the microscope. Without microscope, it is like we cannot do. And this is a case of intramedullary, like within the spinal cord, which is spreading from the C2 to C5 level, intramedullary lesions. Here we do with the intraoperative neuromonitoring, like we will not give relaxant during the surgery. We will be giving only the TIVA, which is called TIVA, total intravenous anesthesia. So this is very important. Using a intraoperative neuromonitoring, we will be monitoring regularly. And this is another one of my favorite surgeries, that is trigeminal neuralgia. Here one of the rare entity is called vertebrobasilar dolichoectasia. Like here you can see the artery, basilar artery is it is curved, and it is actually here it is, you can see the artery, it is touching the trigeminal nerve on the opposite side. So this patient was with a severe trigeminal neuralgia pain. We can see the basilar artery which is compressing the trigeminal nerve. This is the basilar and this is the trigeminal nerve. So the basilar has been pushed and Teflon, I put a Teflon patch in between. So this is one of the little vertebrobasilar dolichoectasia is a rare cause for trigeminal neuralgia, but routinely it's the superior cerebellar artery is the cause. Even sometimes veins also can cause this trigeminal neuralgia. Even epidermoid also. This epidermoid also can present as a trigeminal neuralgia. And another one thing is using a fluorescence for brain tumors surgeries. So I attended this in the Germany, like using a fluorescence for glioma surgeries and abscess. Here we can see one young guy with a large tumor. So the fluorescence is at the time of nearly some like 30 minutes before the tumor. We give fluorescence dye to the patient intraoperatively, and the surgeon under the microscope, under the fluorescence light, it looks like this. The tumor alone, otherwise that's a normal light and this is the fluoro. The tumor alone look bright, yellowish, So we can see separate. Usually in like meningiomas and all, we don't need this fluorescence, but in gliomas, yes, there is a definitive role in using the fluorescence. Tumor appears, more brighter. And this is the post-op case. It's a high-grade glioma. Actually, it's a grade 4 glioblastoma multiforme. It's another CME angle tumor. It's a large tumor. Actually, whatever the cases I am showing here, most of the cases, nearly 90% of the cases are being from this region. And I thank the physicians who are supporting me. It's a post-op case, near complete removal. This is another case of meningioma. Usually meningiomas are like complete removal is possible. But this is a grade 3 meningioma. Grade 3 meningioma will recur again and again. Here, I removed even the part of the bone which was involved in by the meningioma. But still, this patient came with a recurrence. It's another very large CME angle tumor. Complete resection was I could achieve. With this oncology, I think I'll just show a few of the pediatric cases which are interesting. It's a child with spinal dermal abscess. There was a defect, infected tract, and then there's a tumor, infected dermoid. Another child with a large posterior fossa. This in the pediatric age group, this is the commonest midline posterior fossa tumors with the obstructive hydrocephalus is the commonest presentation. So here we do sometimes shunt initially and then the tumor resection. But sometimes yes, I do just only intraoperative UPD and the tumor resection. So another child with seizures, it's a DNAP calcification we can see. So after the simple surgery, you remove it, the child will be completely free from the seizures. So another child. ADS child with so another one child with the nasal encephalopathy. You can see the very wide gap between the eyes. So there was a gap, bone defect with an encephalopathy, large part of the brain tissue has been collapsed. So there was a bone defect, significant bone defect. So I used a bone here. It's a new bone. I kept there and closed the encephalopathy gap. And this another is foramen. There is a cerebellar descent here. It's an anal cherry malformation. So this even in the young, like 6 years child with a foramen, the surgery is foramen migrant decompression for this. And I'll just show a few of the vascular cases. There is a ICA, it's an aneurysm. You can see headache. They present with sudden unresponsiveness. There is an aneurysm here, subarachnoid hemorrhage. So this is an ICA here, this is an aneurysm, this is optic now, so it is compressing here. So this clipping was not microsurgical clipping. It's a short video of that, how we do the clipping. And this is the post-op view of the patient. It's a post-op and this was one of another, it's a carotid endarterectomy surgery. Now actually this is a little less being done because of routine stenting. So I guess all this this all routine advanced, I could say advanced neurosurgery. It's a child with another aneurysm. It's a clipping was done. It's a 14 years boy with aneurysm. So I guess this routine, rather than the routine trauma and the routine spine, so this is what is being done routinely at KIMS KURNOOL. So I guess I am doing advanced neurosurgery at KURNOOL. I guess so. So these are the machines, which is the state of art, the drill, CUSA, navigation, and the fluorescence microscope, endoscope, intraoperative monitoring. So to conclude, under one roof, all the globally advanced techniques now available at our region, with a better cost-effective solutions for neurosurgical problems, the world-class skill and technically brought to the convenience of our Tier 2 city population. So with this, promising to be always supportive to lend my hand for strengthening of our regional medical community and hoping the same from you. Big thanks to IMA and thank you for patience listening. Thank you.
Thank you, sir. No. Next, I would like to call Dr. Aditya Raj.
I am Dr. Aditya Raja. I am the operations head for KIMS Hospital, Kurnool, AVP operations. Thank you so much, sir. Nice meeting you all. So we have 24/7 emergency critical care, advanced diagnostics, and super specialty departments to all we have. There we tried in nursing and paramedical teams also. We are also focused on infection control, and we are taking the cardiac interventions, and also we have a beautiful cath lab. And we are performing like neurosurgeries, neurointerventions, neuroemergencies. And recently we are going to start our IVF center, going to start next month. And also we are planning of oncology department. We have DNP organic seats. So far we are doing 80 kidney transplants and 10 liver transplants done so far. And one more information that in Nandyal, Dr. Suman sir will be available every second Wednesday of the month. Please support for the cases. Varda sir, near Varda, neuro case. Thank you so much, sir, for your time.
Thank you, KIMS Kurnool, for sponsoring the CME. And all of you can join the dinner now.